Well, welcome and thank you so much for tuning into this lecture here today. The title is Diabetic Retinopathy, Imaging in the Future. I'm Carolyn Majcher. I'm Associate Professor at the Oklahoma College of Optometry in Tahlequah, Oklahoma, and very pleased and fortunate to have Munish here with me today.
Hey, thanks for the nice introduction, Carolyn. Yes, my name is Munish Sharma. I'm Chief of Optometry for Kaiser Permanente for San Bernardino County area. And we're really excited to share some really nice cases and a nice presentation on imaging and future of diabetic retinopathy. All right, so diabetes management on a population health perspective is a three-part problem. The first problem is, we all know that it's the number one cause of blindness in people from 20 to 74 years of age. And we knew from, I will say now 50 years ago when DRS report 14 first published, that we can actually prevent the blindness in 2/3 of the patients if you're able to catch it early and manage it adequately. But at the same time, those of us who have been practicing for a few years already know that traditional screening methods that we're using right now aren't very perfect. So almost just 40% of patients who need to be screened are screened according to National Committee of Quality Assurance recommendation. So that leaves a lot that desirable that needs to be done. The second part of the problem actually is demand for diabetes care. We all know diabetes is going to increase in prevalence from 14% to 21% of population by 2050. That means the demand for diabetic retinopathy or vision-threatening diabetic retinopathy screening is going to implode in itself to 19.4 million patients by 2050. Now let's look at the supply, and we're going to talk a little bit more about it later on. There's going to be only 2% change if we just look at ophthalmologists from 2005 to 2020. So looking at it in a different perspective, let me just sum it up. So the incidence of diabetes is increasing by around 1.4 million cases per year. With the present situation in which we get around 467 ophthalmologists graduating and 1,557 optometry graduates graduating from optometry school, the ratio doesn't look very pleasing. We got a situation in which we have 2,000 new eye care professionals coming who have to manage 1.4 million newly diagnosed patients. That means we are looking at something like one eye care provider looking at around 700 patients or so a year. So that is a challenge. So today's talk is about how we can manage this. The first part of the talk will talk about how imaging can help in managing this large volume of patient coming in. So Carolyn's going to talk about the diagnosis and management by optometrists actively using new imaging modalities. And then we'll talk about how we can do population care or how we can manage the population end of it. So Carolyn, I'll have you start.
So Munish, you just said we're not doing enough screening already as is. There's going to be increased demand to do even more screening, but not enough providers to do it, right? So we have this major challenge as eye care providers and as optometrists to see more patients, to see them faster, more efficiently. And like you said, I think one of the solutions here to this problem is imaging and technology. And so I'm a very diehard believer that multimodal imaging and wide field imaging can make our job a lot easier. We can detect diabetic retinopathy earlier, particularly proliferative diabetic retinopathy earlier, macular edema earlier, and we can prevent vision-threatening retinopathy, which is what it's all about, right? We don't want patients to wait until they're symptomatic to come and see us if we could, stop that from happening to begin with and be preventative in our care.
So that means we have taken the angiography capabilities to pretty much every optometrist in every practice in the country, which is amazing compared to when I started practicing. So no, definitely, completely agree.
This newer generation coming on, myself teaching in optometry school, they just grasp onto technology and really understand it and can utilize it. So the future's bright. My personal protocol for imaging diabetic retinopathy, I like to do wide field or ultra wide field Claris fundus imaging, just detect any peripheral diabetic retinopathy lesions, and then OCTA angiography montage. And the purpose of that to detect any early proliferation, try to quantify the amount of peripheral nonperfusion, predict what the patient's risk is to go on to develop proliferation if they don't yet have it. And then, of course, just a regular macular OCT to look for cystic macular edema that could perhaps be treatable, and to try to relate how close to the center of the fovea that is. Certainly, if it's closer to the center of the fovea, it's more treatable than extrafoveal macular edema. I will occasionally do a 3x3 macular OCT angiography if I suspect that a patient has macular ischemia. So if a patient has reduced acuity that's unexplainable, They don't have any macular edema. It may be that there's an enlargement of the fovea vascular zone and actually some ischemia within the macula itself that we're really only able to image with angiography. And so I will do that if I suspect that that's an issue in a patient. And then looking for early proliferation on the disc or neovascularization of the disc. The 4.5 millimeter optic nerve head cube does a wonderful job of helping you find very early neovascularization on the disc. So if I have a patient that I'm thinking is like severe non-proliferative, I'm going to image them with angiography to look for early proliferation to make sure I'm right and I can be confident in my diagnosis and monitoring that patient. So just to give a little bit of introduction to the technology that's out there, wide field versus ultra wide field imaging, we hear these terms thrown around a lot, but what do they actually mean? So wide field imaging, by definition, needs to go at least out to the vortex vein ampulla. A single shot wide field image on a Claris actually gives you more than that. So we can get beyond the vortex vein ampulla and actually get 133 degrees in diameter with just a single shot image. And then the ultra wide field, by definition, is about 200 degrees in diameter. And here we have a ultra wide field shot called an auto montage that's done with the Claris, where this is 4 images that is montaged together, and these are true color images. OCT angiography montage, I think, is also very important, so we can see what's going on with the vascularity and the capillaries out in the periphery in these diabetic patients, because a lot of the non-perfusion is not in the posterior pole, like you would think. It's going to be out in the mid-periphery and the periphery, and I have some cases here to kind of prove that to you. But you have 2 options in terms of OCT angiography montage on the Zeiss Cirrus instrument. And so a 14 by 14 millimeter montage, which takes 5 individual 8 millimeter cube scans and then montages those together. This is one of my go-to montage that I do on most patients. And then another option you have is a 10 by 14 millimeter montage, which montages 6 millimeter cube scans.
I know with the new software upgrade, now actually you can go up to 12 by 12 cube. Isn't that really cool? I think we'll get much better, bigger field and much better imaging quality.
That is really nice. And in a single shot, so it's going to help you save time. And the resolution is still really good on just the single shot 12 millimeter scan. So this first case, I think, really highlights the utility of just OCT on managing diabetic retinopathy and some more complex cases that can help you have more confidence in your diagnosis and your management of these patients. So breaking up is hard to do. I'm not going to sing it, but this is a 49-year-old American Indian male. He's already been diagnosed with proliferative diabetic retinopathy. He's been treated by retina, is periodically followed by retina, I think every 3 to 6 months. He's had PRP in both eyes 4 years ago. His diabetes, he's done a fabulous job at getting under control. So his hemoglobin A1C is now 5%, but yet his vision is still somewhat reduced 20/40, 20/60. And what we can see on our ultra wide field Claris image here is not even the optic nerve, right? Because it's obscured by all this fibrous tissue, but it looks quiet, right? We don't see any active blood flow in this fibrous tissue. It just looks like involuted or regressed neovascularization. But unfortunately, even with your diabetes being well controlled, the neovascularization being regressed, we can end up with these tractional complications that can potentially compromise vision and cause tractional retinal detachments. And OCT is a wonderful way to image this and monitor progression or change over time. And so we can see his right eye here. This is a really thickened posterior hyaloid, probably with some old fibrous tissue of neovascularization that's clinging to the posterior hyaloid membrane. There's really not a whole lot in terms of way of vitreoretinal traction here in the right eye, but the left eye is certainly more severe. And so we're taking a B scan here through the inferior peripapillary region. It's got this really thick fibrotic tissue on the posterior hyaloid and some pretty significant vitreoretinal traction. I think a really important thing to note is that there is no subretinal fluid underlying. So if I start to see subretinal fluid, that's the beginning of a tractional retinal detachment, and that's somebody that I then feel uncomfortable and I'm going to refer out.
So those are beautiful images. Can you tell us a little bit about how you're able to get such a nice depth of focus and what protocol you usually follow for OCT in these patients?
Yeah, I really like the 21-line raster scan that's available on the newer software upgrades of this series. You are able to condense the scans down so that they're tighter and closer together. So it's almost like a macular cube when you're kind of going through the scans, but the image resolution is higher and easier to see subtle areas of subretinal fluid. So this is an example. This is a different patient here now, but just to highlight to you how you can monitor vitreoretinal traction and detect the earliest tractional retinal detachments possible using OCT. And so this was a patient here on baseline. You can see kind of this V-shaped posterior hyaloid that's causing what looks like just a little bit of traction on the retina. But over 2 months' time, she develops vitreous hemorrhage that's decreasing the quality of our scan. But then we can also see now that there's this associated pocket of subretinal fluid. Right? This is something that's going to make me nervous. I know that now there's some progression of traction. There's an early tractional retinal detachment. This is probably something I'm going to refer to retina and not just manage on my own anymore. Would you agree, Munish?
Completely agree. These are patients which makes a really easy, simple surgery, and the outcomes are really good. And I think it's definitely good to partner up with retina in that case.
OCT is also a great way to assess the status of the posterior hyaloid. So whether a patient has a complete posterior vitreous detachment or not, certainly having a complete posterior vitreous detachment is protective against proliferative diabetic retinopathy developing, and also having any tractional complications of proliferative diabetic retinopathy, such as the tractional retinal detachment, vitreous hemorrhage. When you see a complete PVD, even if there's some preretinal tissue, I feel really comfortable that there's not going to be any sort of sequelae, as opposed to this patient here that has this vitreous that's coming down and is causing some vitreoretinal traction. If it pulls on this NVE, it could cause the vitreous hemorrhage. If it pulls even more, we could end up with a tractional retinal detachment. So use OCT to say whether the patient has a PVD or not, and then you can space your follow-up based on that, right? So this is a patient I feel comfortable monitoring at wider interval than is this patient where I'm going to watch them a little bit more closely. So the second case makes me sad, and the title kind of infers that. The reason being is that this patient, when he came in and he saw the student, he said that he didn't even want to be dilated. So the student came up to me like kind of all flustered about it because they're like, oh my God, I'm going to like fail this encounter because this diabetic patient doesn't want to dilate. But I went in there, convinced him to dilate, and then the student took photos, and then the student came back to me and said, after I took the photos, the patient refused to even look at the photographs, right? So you just get this like sinking feeling in your heart that the patient's like not going to follow through with your recommendations. But the outcome of this case is good. Somewhat sad for me just to present to the beginning. So this is a really young patient, a 29-year-old American Indian male. He's coming in just saying he wants glasses and he wants to get out, basically. He's been already previously diagnosed with severe non-proliferative diabetic retinopathy at his eye exam 5 years ago. He's had diabetes for a very long time. We think it was type 2 versus type 1, but the age of onset, makes me think maybe it actually was type 1. I don't know. His hemoglobin A1C, 8.2%, so definitely could be better controlled. He's already had some amputations, and he's so young. His best corrected acuity is reduced at 20/30. And so here are his Claris images. Over here on the left is just a single wide field shot, and then over here on the right is his auto montage, which is a montage of 4 separate shots. And we can already appreciate that there is some neovascularization, it looks like elsewhere, particularly this large front here in the superior temporal arcade. But there's also a lot of diabetic retinopathy lesions and these dot blot hemorrhages out in the periphery that we're able to image really nicely. And just kind of zooming that up here, we can see he has this area of neo, he has this area of neo, he has this area of neo, and this area of neo down here. And then it also looks like some neovascularization on the disc. OCT angiography montage, this is a 14 millimeter by 14 millimeter montage scan here on the right, shows us the vascular detail really beautifully. And so we're able to see all this non-perfusion, right? And if we look over here on the color fundus photograph, there's nothing there that's cluing us in that this retina is non-perfused. But we're able to see that now with OCT angiography. And he's got a lot of it, right? I mean, there's a ton of non-perfusion kind of up in here as well. It really helps highlight those areas of neovascularization. And you can kind of tell already that the foveal vascular zone looks larger than it probably should be. It's almost 1 disc area in size, which is pretty unusual. And just to put that in perspective, for those of you who are new to OCT angiography technology, so this is a normal patient, what the peripheral capillary perfusion should look like. And then here's our patient that has this massive areas of peripheral non-perfusion and this enlarged foveal vascular zone that you can already appreciate on the montage image. That
used to be a big, I will say, stepping stone between angiography and color pictures from when we didn't have OCTA. If you just look at the macula itself, getting that shot of foveal avascular zone is very precious and is very helpful. And also to educate the patient. If you just show a color picture and they see few bleeds, but it's very different to show that dark black contrast and say how much of the retina is actually dead and is just actually creating VEGF.
Yeah, I agree. It's really powerful as an educational tool to show the patient if they'll look at it. Right?
Yeah.
And so here's his macular OCT. This is just a high resolution scan here right through the center of the fovea. You see there's no cystic fluid in the center of the fovea here. We can appreciate that there's some of fibrous tissue on the posterior hyaloid that's kind of hanging like a hammock across the cup, which is some neovascularization on the disc. Pretty classic presentation on the B-scan OCT here of neovascularization of the disc. So why does he have 20/30 vision if he doesn't have any center-involved diabetic macular edema? And the answer is macular ischemia, right? And so this is a 3 millimeter OCT angiography macular scan. So we're getting really high capillary resolution detail of the foveovascular zone. And so a normal foveovascular zone should have this ring of perifoveal capillaries that's intact, right? Versus our patient where he has these breaks in this perifoveal ring that signifies some ischemia and some irregularity. There's certainly an irregular contour to his foveovascular zone. It's larger than what we'd expect a normal patient to be. This is a 4.5 millimeter OCT angiography cube scan of the optic nerve head. And so you would use this scan to visualize neovascularization of the disc in greater detail and higher resolution. And so what we can see here is this patient has some really extensive neovascularization of the disc. And the vitreoretinal interface, or the VRI, it's a preset display on this particular scan on the Zeiss Cirrus model software. The vitreoretinal interface display is specifically designed to show you preretinal neovascularization or neovascularization of the disc. So if you have someone that you suspect has neovascularization, make sure you're looking at the vitreoretinal interface for neovascularization. I also want to point out just the beautiful detail that we get of these neovascular complexes with OCT angiography. So OCT angiography, the capillary detail is better than fluorescein angiography because there's no leakage that obscures our view. So because this patient has obviously high-risk proliferative diabetic retinopathy, the NBD area is at least like 2 to 3 disc areas in size, if not more, certainly would classify this as high-risk proliferation. No macular edema. My preferred treatment option would be PRP. We referred to retina and they ended up doing PRP actually in both eyes. Both eyes look pretty similar for this guy. He's so young, we know he's non-compliant, and we need to get some permanent laser solution in there. Munish, do you think that your retina specialist would have managed this any differently?
I agree with you. PRP is definitely recommended, as you can see, American Academy of Ophthalmology guideline is. But as we know more about anti-VEGF and how they help in kind of making the retina dry in a better way, the laser uptakes are better, especially this patient with all that non-perfusion area, which is just an area kind of pumping out VEGF on a constant basis. It's nice to have it lasered and calm down. I wouldn't be surprised if the approach would be to just give some anti-VEGF injections to just calm the eye down a little bit and then follow it up with the PRP. Yeah.
Agreed. I think probably a combination of the two is best, right? So like hit it hard first with an anti-VEGF agent, but then make sure you get your PRP in there like long term to kind of hold them steady and through. One of the really important things I think to look at when you're doing OCT angiography montage is there non-perfusion out in the mid-periphery and the periphery? And if there is, how much? And so we can see on these diabetic patients, the non-perfusion is not in the posterior pole, right? The majority of it is taking place out in the periphery. We need to be able to image that, and OCT angiography montage is the way that we're going to do that. When you see a patient that has massive non-perfusion, like this one over here on the right, it's telling you that if they're not already proliferative, right, that there's an increased risk to go on to progress to proliferative disease, and that they would likely benefit from early treatment, whether that's PRP or that's anti-VEGF treatment. And so for patients who are kind of like in this bucket where they're not yet at high risk proliferation, where everyone agrees like, yeah, you definitely got to treat that. Let's say maybe they're severe non-proliferative or they're low risk proliferative. They don't yet necessarily have to have treatment. When would you maybe sometimes treat them early? I think if you're seeing a patient like this on OCT angiography montage that has a lot of ischemia, we know they're at high risk to go on and progress. That's somebody you're more likely to treat than not. So this next case, I want to give a shout out to one of our just graduated residents, Dr. Laura Chan. Our residents really held down the clinic during these COVID times. They were like on the front lines, seeing the emergency patients. And so this was one of the patients she saw, and then she, kind of shot me an image and was like, hey, what do you think's going on here? So I want to give her a special shout out for these cases. My protege, really proud of our residents that have just graduated here. So this particular case, proliferative or proliferative, that is the question. And so this was a 50-year-old American Indian male. He just complained of generalized decreased vision in both eyes. He was previously diagnosed with severe non-proliferative disease back 2 years ago. He's had type 2 diabetes for 11 years. And you may think an A1C of 11.8 is bad, but this was actually an improvement from 13% for him. He also has some sleep apnea, hypertension, some other risk factors for diabetic retinopathy and progression. His best corrected vision, 20/20. And what we can visualize here on his Claris imaging over on the left-hand side, this ultra-wide field, right? He has some dot plot hemorrhages, almost looks like some flame hemorrhages too, right? So we probably also have some hypertensive retinopathy. There's a lot of areas of retinal infarction, or these kind of large cotton wool spot type lesions that help clue you in that there's probably a lot of retinal ischemia or infarction that we're going to see on OCT angiography coming up here. There's no obvious neovascularization to me, right? There's something on the disc that kind of looks funky. So, it's definitely something on the fundus exam I would flag and say, I need to get an angio scan of the optic nerve head of 4.5 millimeter cube to visualize this in higher detail to see if that's neovascularization of the disc or not.
And as we are seeing more of these patients, we are realizing the posterior pole, the old myth that diabetic retinopathy for type 2 is only going to be in posterior pole, is being challenged, because as we are imaging wide and wide, you realize a lot of these patients actually have peripheral, mid-peripheral and peripheral pathology, which the conventional thinking is only present in kind of more of type 1.
A lot of times when I see that there's like these predominant peripheral retinopathy lesions, I'm more likely to think, oh, there's some sort of carotid issue. But I'd say probably only like 1 out of 10 actually comes back with significant stenosis that maybe explains it. So I think the rest of those patients where it's predominantly peripheral diabetic retinopathy, it just signifies to you that, hey, this really is a thing, and this patient's more likely to progress, which I'm going to cover in a case here later on. But when you have predominantly peripheral diabetic retinopathy, you got to watch those patients more closely. I put the follow-up a little bit tighter, knowing that they're at increased risk. So here on the OCT angiography montage, we can appreciate that there's definitely this non-perfusion in the periphery that we kind of expected based on a lot of the cotton wool spot and retinal infarction that we saw on the color fundus photograph. But look like down in this area where there's like this very large area of capillary non-perfusion. If we look over at the retina, there's nothing white, so this isn't any sort of acute infarction. This must have been some past infarction that had occurred in the retina. And OCT angiography is making that visible to us, while, just looking at the fundus, we can't visualize that with fundoscopy alone. And we can start to see that there is, in fact, some irregular vascularization on the disc. We'll look at that in higher detail here with our 4.5 millimeter optic nerve head angio scan. And so remember we said the vitreoretinal interface is going to help isolate out neovascularization for you. And so on the vitreoretinal interface map, we can see that there are some, fairly smallish areas of neovascularization of the disc. We can see this fibrous tissue kind of hanging across the cup. It has some red overlay on it, which means this is actually vascular tissue. This isn't just some sort of regressed fibrous type of tissue. What I think is surprising is that like this area here to me, it kind of looks like fibrous. I don't really see any obvious neovascularization on the disc, but then there's like a very large area of neovascularization there that just really isn't easily visible unless you do OCT angiography.
These are the patients you had to wait for staining of the angiogram for the really late phase pictures to even find it. So it's so amazing you can see them non-invasively now.
And much faster, right? So you don't have to take images that say like 5-7 minutes to look for late leakage on fluorescent angiography. We're able to just get it in a few seconds, taking a OCT shot. On his macular scan, consistent with his 20/20 vision, he doesn't have any central involved macular edema, which is great, but he's still definitely got a problem, which is high-risk proliferative diabetic retinopathy. So I would have graded the neovascularization on the disc probably like 1/3 to 1/4 disc area in size, which is the definition of high-risk proliferation. And so he falls in this bucket again where probably PRP or anti-VEGF would be recommended for this patient.
And I agree. I think first turnaround in this kind of a patient where the macula is relatively spared is to hit those areas of non-perfusion and make sure we decrease the VEGF production to prevent them from getting macular edema.
You absolutely nailed it, right? This is a guy who's 20/20. We got to keep him 20/20. I completely agree with you. This next case, a lot can happen in 1 week, unfortunately, especially during COVID times when, patients can't really get in to see retina. They're like backed up in their schedule, or a patient can't go because they're ill to their follow-ups. So this was a 29-year-old American Indian male. He's complaining of some increased floaters in the right eye for the past 2 or 3 months and an occasional flash of light. He is monocular, so the left eye has already been enucleated. Fortunately, his right eye has already been treated with PRP about 3 years ago. He's had diabetes for 12 years, fairly well controlled, at least some of the better numbers that we usually see here. His vision's 20/70. Here's his wide field Claris shots. And you can appreciate he has some PRP that's kind of an interesting, like radial starburst type of pattern to it. There's definitely a lot of room for more PRP. Would you agree, Munish?
Completely agree. I think there are a lot of areas spared here. I think he probably had non-perfusion in these areas only. So first time around, that was the only area being hit, I guess.
I think he continued to progress, or they had multiple sessions and he stopped going back.
He never showed up for the second session. Yep.
I think
the superior half is missed. That's probably what happened.
But I want to take particular note of this area right here, where it looks like it's some neovascularization elsewhere. I'm kind of mag that up for you here. I mean, this whitish stuff is some fibrotic tissue. There's some pretty large, like feeder vessels that go into this area of neovascularization elsewhere. This is the raster scan through that area of neovascularization that we were just looking at. And so we can appreciate that the posterior hyaloid is kind of thickened and coming down here, maybe causing a little bit of traction. And then what OCT highlights really beautifully here, and what I want to point out, is this subtle vitreous hemorrhage that we can't visualize with fundoscopy, but we can see it on OCT. And certainly the patient's complaints are consistent with it too, right? He's saying he's seeing some increased floaters. He's probably seeing these like subtle red blood cells in the vitreous that we can image with OCT. And I also want to point out the vessels of this neovascular complex that are kind of sitting and scaffolding attaching to this thickened posterior hyaloid here. This is a 6mm OCT angiography cube on that area of suspected neovascularization. And this is the vitreoretinal interface map. So we said stuff that shows up on here is probably neo. So indeed, I mean, he has this large, like frond or flower-shaped type of neovascularization elsewhere. On the B scan, remember that like thickened tissue that was on top of the retina? Because it has this red overlay on the angio B scan, we can be assured that there is actual blood flow, moving red blood cells in that preretinal tissue. So this is neovascularization versus just some fibrous tuft. So our resident, who is absolutely excellent, put in a referral for the patient for 1 week to be seen by retina. Unfortunately, I don't know what happened. I mean, this was back during COVID times that he didn't get referred out. 8 days later, he comes back and says, I'm seeing even more floaters in the right eye that happened last night. It's like looking through some sort of gauze in my vision. Remember he was 20/70 before, which wasn't great, but now he's count fingers, which is even worse, right? And this is his only seeing eye. And how does somebody like this even function? I mean, that's a whole nother thing to talk about on a different day. This is the before shot. Remember we had this area of neovascularization elsewhere. We now have a pre-retinal hemorrhage in that same location. So there must have been some more vitreal traction that occurred that pulled on the neovascularization. It caused the pre-retinal hemorrhage. The haze that we see throughout the entire photograph, I think, is a vitreous hemorrhage. And then we have some blood kind of settled in the inferior retinal shot here on the Claris.
It's an amazing shot considering the vitreous has all the haze from blood inside. In spite of that, you're able to see all the retinal details. So I'll definitely give compliment to your resident. She did an amazing job in taking those pictures.
This next case is a 63-year-old American Indian male. He's just coming in for a routine exam. He's been seen by retina past, and he's coming in asking, like, do I need to go back and see them anymore? Because for us, like, going to see retina is an hour-and-a-half drive. And so a lot of patients don't like to do it. And if they can, spare that, they would prefer it. He's already had PRP in the left eye here 2 years ago. We can see that very nicely here on the wide field shot. It looks like pretty adequate PRP2 compared to the last patient that we were looking at. His diabetes he's had for 8 years, fairly well controlled, getting there. Distance vision is very, very good, so 20/20 vision. On his Claris fundus shot, you see he actually doesn't have a whole lot to see, in my opinion. I mean, there's like a common little spot here. It does look like there's some irregular vascularization, and just looking at it, it's hard for me to say, is that IRMA or is that neovascularization elsewhere? And because it's so small. So that's an area where right off the bat, I'm going to ask the student, like, you need to image that area with OCT angiography to see if is that IRMA or is that neo. And then there's a sort of sclerosed or ischemic vessel right here. And this irregular, like patchy coloration of the retina, I think helps clue you in that there may be some non-perfusion in this region that we're going to be able to better visualize with OCT angiography. So this is OCT angiography Montage. If we look at this area of irregular vascularization, we're saying, oh, maybe this is IRMA. We missed this area completely, right? And yet that seems to be a very large area, perhaps, of neovascularization elsewhere that's just more subtle on fundus exam. It's got a lot of peripheral non-perfusion. I think another key take-home point here is that neo and IRMA in general tends to grow at the border of perfused and non-perfused retina, like that watershed type area, some people call it, for whatever reason. So here's this neo, and here's like the border, right, of perfused retina and non-perfused retina. That's where you want to look for neo. That's where it's going to happen, I think, the majority of the time in my clinical experience.
Yeah, I agree. And patients who already are being lasered, their neovascularization elsewhere is not going to be as juicy, as big as you will see in the patients not been lasered. So you're right. This patient would have to travel 1.5 hours just to get an angiogram if he didn't have this option. But you really definitely saved him a trip. He can probably go for treatment now.
So with the OCT angiography Montage, what's really nice with the newer software versions is that we can still isolate and segment out different depth locations of the retina. And so this is the superficial capillary plexus over here on the left-hand side, and then this is the vitreoretinal interface display that helps isolate and pull out this area of preretinal neovascularization for us. So know that that's available to you, that you can still segment out and look at your typical preset NFOS displays, even when you're doing Montage OCT angiography. Looking at this neovascular complex in greater magnification with this 6mm scan and our cross-sectional B scan, we can appreciate that that tissue is growing up out of the retina. I mean, that's really like the definition of preretinal neo, is that it's on top of the retina. It's kind of clinging to the posterior hyaloid here. It has this red overlay on it that helps clue us in that this is perfused. And then the vitreoretinal interface helps isolate that out for us. And we can see that in really nice detail and quantify, how large that is, which in my opinion really isn't a very large area of neovascularization elsewhere. His macula was clear. He didn't have any macular edema. Remember, his vision was good. He was 20/20. We can appreciate that. I mean, he's got this beginning partial posterior vitreous detachment. So he might be at risk of some traction on that neo later down the line. But right now it looks like he's in a really early phase of PVD to me. And so he's someone I would have classified as low-risk proliferative diabetic retinopathy. He doesn't have any preretinal hemorrhage. He doesn't have any vitreoretinal traction. I personally would feel comfortable just monitoring him every 3 months in our office, making sure he understands really closely the symptoms of a vitreous detachment and to come back if they occur. I don't think it would be unreasonable, however, to refer for consideration of anti-VEGF injection, which he would likely benefit from as well. So I would have a discussion with the patient and let them kind of dictate where we go from here.
I agree. So access to the care is definitely a challenge here, and that should be part of the decision making. But if we didn't have those tools to monitor, probably I would have been more comfortable referring out. But with those tools, you can monitor it. If somebody who already had lasers and is developing this neovascularization elsewhere, which is very subtle, but the macula is spared. So that is another good thing for the patient. So yeah, probably anti-VEGF will help this patient, or we will send it out for that. But in case you can monitor. So I agree with the treatment.
I think you made a really important point, which is the technology makes you feel more confident, right? That you can monitor something like this on your own and really hold on to patients longer than you could have otherwise, that you thought maybe you had to refer when you maybe don't. I just have a few slides on this particular case. So this was a 45-year-old American Indian female. She was previously diagnosed with proliferative diabetic retinopathy. That's fairly extensive given her young age. She's already had PRP in both eyes 6 years ago, had diabetes since a very young age. So she's been diabetic for 20 years, still not well controlled. The vision slightly reduced to 20/30. If we look at just the wide field Claris shot here, it's sort of underwhelming compared to what we're about to see here with OCT angiography. So you can see, I mean, there's like some fibrous tissue. This is a really heavy PRP, like a retina specialist just went at that, which I think in her case is good because she's still young and she really needs some protection. And I think that's probably a good thing for her here. But despite that, I mean, you can kind of already appreciate there's still some like large, mature neovascular vessels here in the superior temporal arcade, some irregular vasculature up in here. But most of the stuff down here kind of looks fibrotic based on just the fundus photograph. If we look at it with OCT angiography, what I think this image demonstrates beautifully is the difference between mature, involuted neovascularization, which I think is this up here, versus active, growing neovascularization, which I think is down here. And so the difference to me is on active neovascularization, you have this like frond, like leaves on a tree, right? Like you have this frond of like looping capillaries on the edge of the lesion. You can kind of appreciate that down in here too. Versus this up here, like these are some very large, mature, thick caliber vessels. But this is probably a very old, long-standing neovascular lesion. Like you can inject this to death and like this thing is not going to dry up, right? This is always going to be here. It shouldn't surprise you. But I did refer her, the reason being is that I felt like this stuff down here looked more active just based on the morphology of the neovascular complex. And look how hard it is to see with just the fundus exam versus what we're seeing with angiography here. So this case, he's just coming in for a routine exam. He really doesn't have any complaints. He's had diabetes for 20 years. His vision's good, 20/20. Here's his auto montage, wide field Claris fundus imaging. You can kind of appreciate here on the right eye. I mean, he's got a few dot hemes here and there. There's really not a whole lot going on. Here on the left eye, though, he's got a lot of peripheral hemorrhaging, right? So he's got this dot heme up here. He's got this dot heme over here and here and here. Versus in the posterior pole, yeah, he's got a dot hemorrhage. He's got some common wool spot. But it seems like the majority of the retinopathy is beyond the vortex vein ampulla and out in the periphery. And so something I'm going to term as like predominantly peripheral diabetic retinopathy. And something important to recognize, the reason being is that research has shown that patients that have this predominantly peripheral diabetic retinopathy are more likely to progress. So they have a threefold increased risk of progression compared to those that just have diabetic retinopathy in the posterior pole. And they also have a fivefold increased risk of progression to proliferative diabetic retinopathy, which could be vision threatening. And so the take home here is that eyes with predominantly peripheral diabetic retinopathy have a greater risk for progression and development of proliferation. So you need to watch them more closely because you know that they're at higher risk. So the take home message, multimodal imaging, wide field imaging is absolutely, I think, a major component of the solution to the challenge that we're facing of optometrists, where we have to see more and more of these diabetic patients, get them screened, try to prevent vision-threatening complications, save patients that have good vision, stabilize them, and keep them there. And so wide field fundus imaging with like the Claris and then Montage OCT angiography imaging is going to help you more accurately stage diabetic retinopathy. You can detect the earliest proliferation possible, have confidence in your diagnosis and your staging of diabetic retinopathy, and do it faster when you have the technology available to help you. OCT angiography is going to allow you to detect proliferation earlier. It will allow you to definitively distinguish between IRMA, intraretinal microvascular abnormalities, which you can watch, versus neovascularization elsewhere, which is early proliferation and it is higher risk for tractional complications. Eyes with predominantly peripheral retinopathy have a greater risk for progression. So those are individuals that you want to watch more closely. So when you're taking those wide field and ultra wide field Claris shots, look for those hemorrhages out in the periphery that signify a greater risk for progression. And there's definitely a shifting practice paradigm towards early treatment of diabetic retinopathy. And Munish, I think you mentioned it earlier, there's definitely this paradigm shifting from laser to anti-VEGF agents.
that just makes the retina a little bit more receptive. The inflammation that comes from PRP is decreased. And you're right, there's a big shift from how we used to look at these diabetes patients for early retinopathy, just focusing on the posterior pole, to what we just find now. Actually, peripheral not only indicate the retinopathy, but also the prognosis of how these patients are going to do later on. So that adds a lot of value to be able to image this part of the retina and be able to help patients in their prognosis.
The other part of the solution, which I would love to hear you talk more about, Munish, is telemedicine and accessibility to care.
There's a big need, actually, for having enough of healthcare providers to be able to screen these patients efficiently as we require to have. One approach to manage it, rather than these conditions being followed up or screened in a big institutions, it can actually spread and decentralize itself. So our target audience here is optometrists who are in various kind of practices, from VA to private practice setting. So ideal for our society is that this diabetic retinopathy screening care is decentralized to the small locations, to every practice around. And for even private practice optometry, it is important to partner up with the places which these patients go regularly. So their family medicine doctors, their primary care provider, their endocrinologist needs to be educated that they need to have these pictures done. But a little bit different approach, which may not be feasible in every setting, is to actually have cameras close to them. And we as an eye doctors be able to get the information and imaging from these offline cameras and offline locations, and be able to interpret and figure it out whether this patient needs to be continuously monitored or need to be treated in a different way. So if you decentralize, you can really double up the number of locations where these patients can be provided access of care. So one example here is I'm trying to share the diabetic retinopathy screening protocol we're using in Kaiser, which is based on the same principle. It doesn't matter which specialty a patient is about to see. It could be ortho, it could be their OB even. They will be flagged, and the need for a retinal screening image will come up. So these patients will be asked to get the imaging done. And once the imaging is done, these images are sent out for evaluation. And based on the evaluation, you decide whether this member can continue to have imaging done in an imaging center, or they need to be actually seen for face-to-face appointment with an optometrist or an ophthalmologist. When they're getting this testing done in family medicine location, it's also a touch point to reinforce the value of how the comprehensive eye examination is required for them to figure out cataract, glaucoma, and all other different conditions. And these pictures also start an opening point in which a practice can start the conversation, adding further treatment modalities. That's kind of the basic framework is. The question may come, how about the macular OCT, or does the macular OCT have a value in this kind of imaging paradigm? So yes, it does. So that means the patients in the central group where optometrists are going to be monitoring and following up these patients, these are the subset of patients who need to actually have macular OCT done along with widescreen photography. So that widescreen photography is going to help us catch all the peripheral disease that Carolyn just talked about, and macular OCT is going to help us catch that subclinical macular edema. And that is a big paradigm shift when it comes to telemedicine for diabetic patients. I'm going to go into a little bit more detail later. Looking at just an overall summary, what's the benefit of transitioning into telemedicine, or what are the benefits to we as an optometrist in our practicing adopting telemedicine is it's good for patients. Good for patients as in we know that screening rates are improved. We talked about 40% earlier, and actually that number can be around 90% depending on what kind of setting you are in. Once the patients are screened early, they're diagnosed early, we treat them ahead of time. So when they have this earlier fronts of neovascularization, beginning of macular edema, you treat them. And all of us know that the outcome's going to be better if you're able to treat them early. Overall, Carolyn can probably watch in when she show that picture to member with all that blood, sometimes you get that little moment in which they're like, oh, you know, that's actually they see the disease for the first time and its effect. So it just overall helps them improve diabetes control, overall help in vision loss reduction. So how to adapt that into a practice? I think the best way to adapt that in the practice is we as like in this difficult time of COVID-19, isolation, face masking, an asynchronous telemedicine care in which the pictures are taken with these wide field cameras and OCTs by your staff while you're trying to do face-to-face encounters for all the patients in which you have to do face-to-face encounters. And then you can follow it up with an asynchronous visit in which you can go over either via video visit or by even a letter to a patient, tell them what their management plan and future of treatment can look like. So this brings into kind of the big shift that needs to happen in telemedicine in order to make it more capable and how we can enhance our technology. Those of us who've been looking at telemedicine over the time probably heard about the category 1 or maybe category 2 coming in. And just a little reference, this here is American Telemedicine Association's categorization of telemedicine based on level of clinical validation. So what that means is how good and close is telemedicine care given to a patient compared to an ideal setting, for example. So for example, category 1 and category 2 is barely able to figure it out if patient has a retinopathy or mild retinopathy, or maybe they need to see an eye doctor, but not exactly able to categorize them. But if you go to category 3 is where we actually really need to look into or invest into, because these are the patients in which you're not able to diagnose them. You can go into the level of not knowing about macular edema. You can see if they need treatment and things like that. And that's only possible if we are able to put together wide field photography and macular OCTs together to reach that diagnostic. So if there's a dilated examination, of course, clinical skills for the providers are great, but of course, OCT is going to help you get one more step ahead. Category 4 is what Carolyn just described. So what that is, we are going to wide field photography now and ultra wide field. So that means our standard of care are exceeding ETDRS. We are really trying to go and provide above and beyond what has been the conventional treatment. And if we are trying to adapt into some kind of telemedicine or make it a part of our practice, it's good to look into category 4 and beyond. And that's going to definitely provide edge to our optometry practices, a competitive edge, and of course, help our patient be caught early, diagnosed early. Do you want to add anything, Carolyn, from your experience, since you are kind of working in category 4 setting pretty much?
Yeah, I had a question for you actually. So when you're doing this screening, like wide field imaging, is this dilated or non-dilated?
Great question. So the patients which are getting screening done at family medicine practice, these technicians are actually optometry photography technicians who are asked to go there and do non-mydriatic pictures. If the patient has a record with us in which we have already ruled out angle closure and all that kind of stuff, which a lot of these patients actually do come to optometry clinics for the routine eye care. So the dilation is what is recommended for all these patients. We all know the image quality is so much better. But since these are optometry technicians or ophthalmology techs, they kind of understand the angle closure, they feel more comfortable to dilate, and that also adds to the quality of care. So depending on patients, so if they're not able to get a good image, they dilate the patient and get the image done that way. Most of the patients are prepared as a part of their pre-appointment counseling that, hey, be prepared for dilation, get a ride.
Let's say you get back like a poor quality image. Do you then put in like a flag on the patient's chart that we need to retake this image, or how does that work?
Yeah, that's a great question again. So all these pictures are pre-screened by technicians who look at it and they grade it and they pre-grade it and get the grading prepared for retina specialists, optometrists, and ophthalmologists to finalize the grading process. So that's where the quality picture comes in. So if the pictures aren't that great quality and is not making meaningful information, that patient is either sent to optometry for another image, or if they're in an offline location, try dilated image. So that QA check really saves a lot of time on the practitioner who's actually making a call on the tail end. And since I said a lot of these technicians are trained in optometry and ophthalmology, they also go and train the trainer programs. A lot of these are trained to go back and teach the family medicine techs to do that. And we kind of see a pattern, we kind of bring that technician back and readdress the training there. That's kind of a categorization. I think that's where the future of telemedicine and imaging comes into play, and that's very important. I'm going to end it with the slide since we are kind of going through this difficult time and really question us, is it really a point where human culture, human evolution is being tested? And I love this quote from Charles Darwin saying that in the long history of humankind, I actually look at the animal kind, those who have learned to collaborate and improvise have most effectively have prevailed. So this is time for us as an eye care providers to improvise ourselves, find new ways to explore, looking at imaging and other modalities so we can go through the difficult times and provide care to our patients. Thank you.
we're getting ready here to get into the Q&A and just continue the conversations in just a moment. So our producer is going to be bringing in Doctors Majcher and Sharma so we can continue the conversation. And hey, there you guys are.
Hey, how
Thanks
are you
for sharing
guys?
those cases. Good, good. Thanks for sharing the cases and the images and providing all your great insights and treatment management, imaging, and everything else. So I'm going to take a look here and see if we've got some questions that came in, and we can pick up where you left off, really. So it looks like there are some questions, and I'll throw the first one out there. What baseline testing do you obtain if a patient comes in for an annual diabetic exam? So if you want to answer that first, Dr. Majcher.
Certainly. On all patients, regardless of whether they have retinopathy or not, I'm going to do an ultra-wide-field Claris image. So it's just 2 shots. It's really easy for the patient. That helps me actually sometimes find lesions that I may have missed on fundoscopy alone. And then if they do happen to have retinopathy, it's a great way to document that. If they have any degree of diabetic retinopathy, I'm usually then also doing OCT, so like a macular cube, especially if there's reduced visual acuity. And then if there's severe non-proliferative diabetic retinopathy or worse, I'm most definitely going to be doing OCT angiography montage. The reason being is to try to find subtle areas of neovascularization I might have missed. And then also just to grade that degree of peripheral or mid-peripheral non-perfusion. So I know how closely I need to monitor them, how great the risk is for them to become proliferative in the future if they're not already. And then if they have decreased acuity without macular edema on conventional macular cube OCT imaging, I'm then going to do some OCT angiography pretty tight in the macula, like a 3 millimeter cube, to look for macular ischemia that might explain why the vision is decreased.
And
How about
Dr.
you,
Sharma?
I'd love to see what you say.
I know. So, well, the patient which we tend to see in typically optometry are already somebody who has been imaged, and either they had an inadequate image to begin with. So we are kind of looking at the things a little bit backwards. So by the time patient comes to see an optometrist, they actually need to have an old conventional DFE. So you go ahead and do that, and then subsequently, if it looks like the vision is decreased, as you said, you're going to have to go with the macular cube and look at macular OCT. The patients who have moderate diabetic retinopathy are already going to have a macular cube done. So that is something which is part of an MDR program, as we discussed earlier. So by the time they come to optometrist, the only reason will be they had a poor quality image or there is something else going on. That's why they need to see a doctor. When it comes to PDR and all those patients, based on the protocol, kind of go to ophthalmology to begin with, and they are managed in that side. So yeah.
Yeah, fantastic. And I think that transitions well into the next question here. I'm just going to read it out. Based on patient hemoglobin A1C levels, how often do you recommend a DFE? So, Munish, if you want to start this time.
Yeah, no, definitely. So if you look at 2016 American Academy Ophthalmology's preferred practice guideline, the take is to go for the patients and get the examination done at the frequency based on actually how their diabetes status is. Like if it's a mild retinopathy, 12 months, you can maximum go 15 months. What is interesting here is if the A1C is high, like you have those 9s and 10s and 11s and 12s walking around, you probably need to have them come in at 6 months until their diabetes is well controlled. So that's kind of a protocol we tend to follow. Again, you know, if at some point it looks like they need treatment, they need to be sent to that way. Yeah.
Yeah, I agree with you. I think it's really important that you are in compliance with the standard of care documents, which is the American Academy of Ophthalmology Preferred Practice Patterns and the clinical practice guidelines by the AOA, both of which have been updated in 2019. So mild, I'm usually following 9 to 12 months. Moderate, usually 6 to 9 months. Severe, every 3 months. And then if there's any degree of macular edema, I'm going to follow those patients a little bit closely, even if the retinopathy is mild. So usually about every 3 months if there's any diabetic macular edema present. For me, I think the 2 biggest risk factors for diabetic retinopathy is not just poor glycemic control, but actually the duration of diabetes. So if it's a patient that's had diabetes for, say, like 20 years, that's probably somebody that I'm going to monitor more frequently than somebody that's just had maybe they have a hemoglobin A1C of 11% or something outrageous, but then they've only had diabetes, say, for 3 months. That's probably somebody I can still let go a whole year versus someone that's had diabetes for 20 years.
Yeah, some general questions just around referrals. So for recent grads who aren't sure up to what point of diabetic retinopathy that they're comfortable monitoring, at what point do you recommend a definite referral to retina?
I'm happy to answer that one.
Yeah, with your background, I figured that'd be a great one. So
yeah, I think at severe non-proliferative diabetic retinopathy, that's where you would start sometimes considering early treatment with even anti-VEGF agents or perhaps even early PRP, although that's, you know, unlikely. But that for me is the cutoff where I think most optometrists should start referring. If there's any center-involved diabetic macular edema, I also think that that's something that you should be referring out for a consult. How about you, Munish? Do you agree?
Yeah, I agree. You know, the time has changed. We don't talk about CSME anymore. So that thing is something we all know of, those who are practicing. So whenever you see there is some center engaging a macular edema, I think it's the time to start doing referral. Since we work in conjunction very close with ophthalmology here, we tend to kind of push the envelope when it comes to looking at severe retinopathy. And when it looks like these patients are likely to develop these big areas of hyperperfusion, it's good to engage retina at that time. Yeah.
Yeah, we've got just a few more minutes before our next session starts, but we've got a lot of great questions. So we'll try to get to all of them, move through them quickly. Do you treat patients who develop retinopathy resulting from dropping their hemoglobin A1C too quickly any differently versus normal diabetic retinopathy? So I'm not sure who might want to.
I love the question. And I was like, I wish that I actually had encountered that opportunity where a patient got their diabetes so well controlled that it caused retinopathy, which is a phenomenon that definitely occurs. I can't say that I've ever been in that scenario myself. Munish, have you?
So yeah, so the great question actually, this is described in literature, of course, and if you look at the, again, peripheral practice guideline, the standard of care doesn't actually want you to distinguish a lot. These are the members. If you start having macular swelling, it's good to kind of, you know, start working on anti-VEGF at that time. If you're having a wide areas of hyperperfusion, you're having early neo coming, you know, anti-VEGF has taken a place where it's very non-destructive. You can go ahead and start managing the patients, and you can, you know, other than very low risk of infection, it's fairly safe. So you can go ahead and start treating these patients with anti-VEGF and kind of see how the outcome looks like. If things look like they're turning back for good, you probably don't need to laser them. But that gives us a little bit stopgap time to kind of think and plan about it.
And just a couple last questions. I'm going to try to lump them all together before the next session starts. They're around it looks like billing and coding perhaps. So I think these came in towards the tail end of your presentation, Munish, when you're speaking about your workflows and everything else. But question is scanning laser imaging considered equivalent to fundus photography? And I'm going to give you a little bit extra context here. Is diabetic screening being billed or charged? And if a patient comes in for a diabetic exam and you do not find any retinopathy, can you still bill for imaging? So really 3 questions in one. So I'll let you.
You know my answer on that one. That's why you put them together.
Yeah.
So my answer is straight. I work in an HMO shop. We get the money in the beginning. So it's not like we bill for any services. Having said that, we really pride ourselves in providing one of the highest national coverage for diabetic retinopathy. Like it's over 90%. So I have a different philosophy here. We most of the time don't bill after imaging. It's all done ahead of time. Our providers do code the imaging, and they do code for whatever level of testing is being done, because that's what take away the patient's examination due requirement. So when an endocrinologist or a PCP looks at it, that's what it is based on. Probably Dr. Majcher will have a good intake into about billing of these things, but we actually don't. You know, it is all kind of HMO shop. We already get PMPM payment. Yeah.
I think, unfortunately, both of us are kind of in a situation where we don't have to do our own billing and coding. So I have a lot of ignorance in that area. Unfortunately, I'm so sorry.
Yeah, that's the best position to be in, right? I don't want to have anything to do with that part of it. I don't blame you. But
love living the good life over here. What can
yeah,
I
for
say?
sure, for sure. Well, thanks both of you for taking the time to share your cases and run through everything. A lot of people have been asking about the recording. For those of you, yes, the answer is yes. This will be available on demand after the event. We'll send out an email where and when you can find it. So stay tuned for that. Doctors Majcher and Sharma, thanks again, and we'll speak to you guys hopefully soon.
Thanks for having us.
Take care, guys.
Take care.
Take care.